pulmonary embolism is a major source of morbidity and mortality. It can result in loss of limb, loss of life. It is certainly difficult to treat. Abdominoplasty has the highest incidence of VTE in our patient population. The majority of cases described in our literature involve abdominoplasty. Risk assessment and prophylaxis, if indicated, is paramount. General accommodations have been developed, but the existing literature is insufficient to provide definitive guidelines on our typical outpatient abdominoplasty, which typically has a lower risk. There's a vigorous debate among our colleagues in terms of medication, dosage, timing, and length. Again, especially in the ambulatory aesthetic patient. I'm going to attempt to identify the pertinent evidence, the facts, regarding chemoprophylaxis. VTE is non-discriminatory. It affects a wide spectrum of patients. You can't just look at someone and say, you're at high risk for VTE. My task, and our task, is to identify a small nest of people in this group who are at greater risk and offer them either no surgery, rehabilitation before the surgery, because it is an elective procedure. This was discussed yesterday. Mechanical measures, which obviously have a very good risk-benefit ratio and non-invasive, and chemical chemoprophylaxis, which is very controversial. Our goal is to mitigate, not eliminate the event. We cannot reach zero. It should not be considered a never event, and I object to that nomenclature. DVT can present in a multitude of ways, and it may not be the classic location. We may miss it preoperatively, hence there's discussion about utilizing imaging techniques to detect occult DVT before surgery. Preoperatively, you may not indicate by looking at the patient, but what you can do is image the limbs at risk and perhaps prevent a intraoperative death. Between 10 to 20% of intraoperative DVTs present at the time of surgery. And so again, 20% of DVTs are intraoperative. Our goal is to interrupt the triad. We want to interrupt the cycle of intravascular wall damage, stasis of flow, and the presence of a hypercoagulable state. The intravascular vessel wall damage is a source of research. I think the technologies of the future may not focus so much on anticoagulation as we think of it now, but on newer technologies to lower inflammation in the vessel and perhaps facilitate flow. The deep vein thrombosis may emanate from other parts of the body besides the leg, but it is most common in the leg. Certainly, mechanical, which have a very good risk-benefit ratio, should be considered in all of our patients. There we go. Various chemicals, both topical and injected, have been utilized to act in different portions of the cascade. The literature is conflicting in terms of which agents are optimal. The oral agents are not FDA approved for prophylaxis in our patient population. They are approved in the orthopedic literature, but not in our literature. The oral agents, as we know, don't have a predictable reversal agent. The injectable agents have a reversal agent. But the cascade is complex, and the number of places to go against the cascade are multiple. This is Dr. Cabrini. He's still alive. He's about 82. and he gave us a scale. All of us in this room are familiar with it. He also did a YouTube video recounting his own experiences with DVT. It's a heartfelt video and worth the view, and he really explains the scale, how it helped him understand better his own diagnosis. This scale needs no introduction to this factor. I think the main goal of this scale is forces the surgeon to think. It forces the surgeon to think down, and what am I overlooking? Am I overlooking a history of multiple failed pregnancies? Am I looking at a patient who had some sort of family history that may not have been picked up earlier? The main goal is it forces you to look at all these factors and make a decision whether you're going to operate, not operate, and what sort of prophylaxis you're going to use. The scale has been modified significantly over the years to try to make it more plastic surgery specific. The Cabrini risk management scale is trying to be more in tune with our patient population, but it is clearly a work in progress. The most recent modification, which has been peer-reviewed and has international acceptance, leaves out the risk factors of COVID. It leaves out the risk factors of international travel. It leaves out the risk factors of ethnicity. So it is a work in progress. It's not the definitive tool, but it's the most reliable predictive tool that we have. So how long after surgery do you worry about a blood clot? As I mentioned, about 20% of the blood clots occur during the course of the operation, hence the rationale for preoperative anticoagulation. The majority of blood clots occur between the 2nd to 10th day, which means that after 10 days, the patient is still subject to a blood clot, but not as high as it would be up to 10 days. But the risk remains elevated for up to 3 months, 2 to 3 months. There we go. As we know, our task force in the ASPS 2011, July, looked at all the available literature, which I'm not going to summarize here, and they basically felt there was 2 conclusions. First, there was level D evidence that the Cabrini scale should be utilized to strongly consider patients for extended chemoprophylaxis. Extended means beyond 3 days. It could be 10 days, it could be a month, but beyond 3 days would be extended. They also felt that there was good evidence, grade B, that we don't really have to routinely use this. Although many people do use it, approximately half of board-certified plastic surgeons do not use chemoprophylaxis routinely in the low-level patients. The patients that were looked at in the ASPS task force were folks that were having greater than 60 minutes of surgery. So their conclusion in 2011, they should strongly consider the option to use extended postoperative prophylaxis in the higher risk patient. But is it time to rethink our strategy? Well, the American Association of Plastic Surgeons made a consensus back in 2016, and they did not recommend adding routine chemoprophylaxis for venous thromboembolism in non-risk stratified patients. This was further discussed by Dr. Swanson, who thought we should reconsider the role of routine anticoagulation. It seems to make sense. You give somebody an injection to interrupt the cascade, and you've lowered the risk for a devastating complication. The problem is that several VTEs were diagnosed at a time well beyond the 1-week period of anticoagulation. And if someone develops a DVT, an occult one, the the first week, it could take 5 weeks to resolve, so they're left uncovered. Interestingly, investigators reported multiple VTEs despite anticoagulation. Those cases have been considered breakthrough cases, and they are not controlled because it's almost impossible to do a prospective, randomized, controlled study with VTEs. Number one, you have inadequate sample size, and number two, there's some ethical concerns. But VTEs have been reported despite anticoagulation. Hematomas are not inconsequential. They can be life-threatening. So what you have to do is weigh the risk of a 35-year-old woman who undergoes a mommy makeover and dies in occult pulmonary embolism versus the risk of bleeding. Most of our aesthetic patients don't require transfusions, and there's still the risk of reoperation for dealing with the bleed. So Dr. Swanson discussed a new approach for prevention and plastic surgery. He reminded us that, again, chemoprophylaxis, specifically oral chemoprophylaxis, is not approved by the FDA for protection in our non-risk in our patients of low risk. Dr. Christopher Paccioni pretty much said the same thing, that we have to be practical, that we can't have a routine approach to all of these patients. Dr. Janis is kind of at the position where I am, is at the discretion of the surgeon. It should be looked at on an individual basis, because only the surgeon knows the planes of dissection. Only the surgeon knows the vascularity. The surgeon is the best person who can determine whether or not the patient should be subjected to the risk of bleeding during abdominoplasty. The literature is very divided about the risk of bleeding. Many papers have discussed an increased risk, but those papers have been countered by other papers that say there is no increased risk. The problem is that it's very difficult to have controlled in terms of length, in terms of the dosage, and there's just too many spinning plates. Facts, VTE can be minimized, but not eliminated, period. Facts, as we all know, prevention is the dominant initial strategy. And as mentioned again yesterday, losing weight gradually before abdominoplasty can have a big impact on your risk for pulmonary embolism. The other mechanical methods that we all use, sequential compression device, perhaps flexing the table, hydration, temperature of the patient during surgery, are all preventive strategies. So we have no all-inclusive recommendations for medication, dosage, or length of prophylaxis. And interestingly enough, surveys show that 93% of patients prefer ultrasound surveillance to routine anticoagulation. This is an image of ultrasound done preoperatively, showing a thrombus in the common femoral vein. It turned out to be a congenital problem, and the patient was turned away for elective surgery, possibly spared a devastating complication. So basically, that's a overview of the literature. It's a broad topic. I think in general, we should strongly consider the option of extended prophylaxis in a patient of Cabrini greater than 7. There's a very low level of evidence if routine anticoagulation makes any sense. And as this entire audience knows, there's no substitute for you looking at the specific patient with an understanding of what you're going to do, because nobody knows better than you what you're going to do, and balancing that with the risk that patient has for an occult pulmonary embolus. That's it.